So in this video we will talk about abdominal pain from Ghai edition 10 page number 303. Let's start. Abdominal pain is a common manifestation of multiple pathologies which vary from benign to life-threatening conditions. The pain may be acute or chronic in nature. Okay, so pain may be what? Acute or chronic in nature. To able to arrive at the diagnosis, careful history and examination and appropriate investigations are necessary. An understanding of pain perception and location of pain provides valuable information. Stretching of the overlying visceral peritoneum or inflammation results in the pain. Fine. When there is stretching of the visceral peritoneum or inflammation, then that results in pain. The pain from the stomach and the proximal intestines is sensed in the epigastrium from the midgut to the periumbilical area and from the hindgut to the suprapubic area. So what is being written here is the pain from that part of the stomach, from stomach and the proximal intestines, they are sensed in the epigastrium. If there is pain in the epigastrium, that means something is there in the stomach and proximal intestines. Okay. But if the pain is in from the midgut, then it goes to the periumbilical area, and if it is from the hindgut, then it goes to the suprapubic area. Okay. The inflammation in the parietal peritoneum causes pain in the overlying abdominal wall. If there is any inflammation in the parietal peritoneum, then overlying abdominal wall is where the pain will be present. Thus, the pain of appendicitis is referred to periumbilical area when the inflammation is restricted to the visceral peritoneum. So, in case of appendicitis, the pain is referred to the periumbilical area when the inflammation is restricted to visceral peritoneum, then only it is in the periumbilical area. But it is perceived in the right iliac fossa when the inflammation involves the right peritoneum. So in appendicitis, if the inflammation is extended up to the right iliac fossa, if the pain is perceived in the right iliac fossa, that means the parietal peritoneum is also involved. Okay. This was something new that we should know. Okay, 1 second. Moving ahead, referred pain is common in abdominal pathologies. Subdiaphragmatic collection may manifest as the same side. Shoulder pain, ureteric pain is referred from the loin to groin, and pancreatic pain can radiate to the back. These are examples of the referred pain. Like in case of referred pain is very common thing which is seen in abdominal pathologies. If there is a subdiaphragmatic collection, then that may manifest as shoulder pain. Okay. Subdiaphragmatic collection may manifest as shoulder pain of the same side. Ureteric pain in the ureters may refer from the loin to groin. Okay, from loin to groin. And pancreatic pain, we all know that it radiates to the back. Now the physicians must distinguish the abdominal pain due to the emergent diagnosis like appendicitis or intussusception from the benign conditions like gastroenteritis or constipation. So we should be able to differentiate the type of pain of appendicitis and intussusception from the gastroenteritis or constipation. Details like the site, duration, radiation, trend, association with the meals, nocturnal pain, associated features, specific triggers that worsen the pain, essential for making the correct diagnosis. So we have to ask about all these things. Examination should be meticulous, including the examination of genitalia, as torsion of testis and incarcerated hernia can easily be overlooked. Acute onset severe localized pain associated with bilious vomiting or distension, absent or increased bowel sounds, localized tenderness or peritoneal signs, rebound tenderness, rigidity suggest a surgical abdomen and needs immediate evaluation. So when will we suspect a surgical abdomen? When there is an acute onset severe localized pain associated with the there is a bilious vomiting or distension, there is bowel sounds which are absent or increased, there is a localized tenderness, there are peritoneal signs of like rebound tenderness and rigidity and guarding. These all suggest what? A surgical abdomen, and that needs an evaluation. Okay. Moving ahead, differential diagnosis should be considered in terms of age, as many diagnoses are more common in younger or older children. So now we are going to read about the various types of DDs of acute abdomen pain. Let's look at the table first. Okay. In this table, there are common causes of abdominal pain which are written. Let's go through this table once. Infants and younger children in less than 2 years of age, if they present with abdominal pain, it can be colic, acute gastroenteritis, necrotizing enterocolitis, urinary tract infection, constipation, intussusception, malrotation of gut with volvulus, incarcerated hernia, and intestinal obstruction. The things written with the black are something that is an emergency. In preschool children in the age group of 2 to 5 years, acute gastroenteritis or colitis, UTI, constipation, lower lobe pneumonia even can present with abdominal pain, acute pancreatitis, ureteric colic, diabetic ketoacidosis, inoxial and purpura, peptic ulcer disease, hepatitis, gallstone disease, intussusception, acute appendicitis, malrotation of the gut with volvulus, intestinal perforation with peritonitis, incarcerated hernia, torsion testis, Michel's diverticulum, and choledochal cyst. Okay, and in older children, what we can suspect is acute gastroenteritis, gastritis, pancreatitis, cholecystitis, pneumonia, acute viral hepatitis, peptic ulcer disease, gallstone disease, Crohn's disease, constipation, UTI, ovarian disease, ovarian cyst, menstrual pain, pelvic inflammatory disease, renal calculi, and these are the emergency conditions which we have to diagnose as early as possible, like acute appendicitis, complicated acute cholecystitis, choledochal cyst, testicular ovarian torsion, intestinal obstruction, obstructed inguinal hernia, perforation or peritonitis, and ectopic pregnancy. Fine. Moving back to where we were, we have to start from acute appendicitis now. This is the first condition that we are going to read in abdominal pain. Acute appendicitis is a surgical emergency and is more common in the older children. Obstruction of the appendiceal lumen by either fecolith or the lymphoid tissue following a viral infection is the initiating event. So what happens is there is obstruction of the appendix lumen. Okay, and this obstruction is either by a fecolith or a lymphoid tissue following what? A viral infection. The obstruction, distension, and the infection in the appendix causes progressive inflammation and subsequently perforation. Okay. What happens is the patient presents with a fever and anorexia followed by pain in the periumbilical area. So there is obstruction, we saw, right, of the appendix lumen, and distension and infection in the appendix causes a progressive inflammation, and it can even perforate later if the inflammation progresses. So the patient will then present with fever and anorexia followed by pain in the periumbilical area. Vomiting follows the periumbilical pain. After the periumbilical pain, there will be vomiting, unlike in gastroenteritis. So in appendicitis, there is vomiting follows the periumbilical pain. Okay, first there will be pain, then there will be the vomiting. As inflammatory fluid spreads, the pain is then felt in the right iliac fossa, in the McBurney's point, towards which the child characteristically points with a finger. A retrocecal inflamed appendix may be difficult to diagnose and may manifest as spasm at the hip. So this retrocecal appendix is difficult to diagnose. And how will it manifest? As a spasm at the hip. The diagnosis is most often based on the clinical suspicion after history and examination. Palpation reveals localized tenderness. There will be localized tenderness in the right lower abdomen, rebound tenderness, guarding, or a mass. In the diagnosis and management, hemogram shows a polymorphonuclear leukocytosis. Urine microscopy should be done to rule out urinary tract infection. So these are the things that can be seen in this. Leukocytosis may be seen. Urine microscopy should be done to rule out the urinary tract infection. Abdominal ultrasound detects a dilated more than 6 mm tubular aperistaltic structure which is not compressible and is surrounded by fluid. So on ultrasound, what will be seen, and when will we say that it is acute appendicitis? When it is dilated to more than 6 mm. Okay. Appendix is a tubular and aperistaltic structure which is not compressible and is surrounded by fluid. Ultrasound has a sensitivity of 80 to 90% and specificity of 95 to 100%. This is very high. So USG is a very good diagnosis, investigating modality for diagnosing appendicitis. Computed tomography may be done occasionally if the diagnosis is in doubt. In up to 1/3 of the patients, the appendix ruptures before surgery. Okay, so in 1/3, up to 1/3 of the patients, appendix ruptures before surgery. IV fluids and the antibiotics for gram-negative and anaerobic coverage should be given in all the cases. So how we have to manage if we are managing this patient of appendicitis, we have to give IV fluids and antibiotics for gram-negative and anaerobic coverage, and early surgery preferably laparoscopic appendicectomy is necessary to prevent the complications like perforation, appendiceal abscess and sepsis. Okay, so we have to prepare the patient for as early as possible for surgery to prevent the complications like this perforation and abscess and sepsis. This was the first condition that we read, and let's read about this now. Causes of abdominal pain as per the site. Okay, if there is an epigastric pain, its causes can be esophagitis, acute gastritis, acid peptic disease, pancreatitis, acute or chronic, and biliary colic. So this was the DDs if epigastric pain is present. If there is umbilical, in the umbilical quadrant, a small bowel colic, strictures, malrotation, tuberculosis, inflammatory bowel disease, intussusception, appendicitis, acute watery diarrhea, and functional abdominal pain. All these present in the umbilical quadrant. If there is pain in the left hypochondriac and right hypochondriac, let's read about first the left hypochondriac. There is spleen, so there can be splenic abscess, there can be infarct, also pancreatitis, acute and chronic, and lower lobe pneumonia. And in right hypochondrium, there can be acute hepatitis, liver abscess, congestive hepatomegaly, biliary colic, acid peptic disease, pneumonia, and subdiaphragmatic collection. In the right lumbar region, there can be a ureteric colic, pyelonephritis, renal abscess, and renal vein thrombosis. Left lumbar region, the causes can be again the ureteric colic, pyelonephritis, same as in this, because there are kidneys present. So in the lumbar region, if there is pain, it's mostly due to kidney causes like ureteric colic, pyelonephritis, renal abscess, and the renal vein thrombosis. If the pain is suprapubic, then it can be proctitis or cystitis. If there is right iliac fossa pain, then it can be acute appendicitis, pelvic inflammatory disease, and tuberculosis abdomen. And in left colic, there can be constipation, colitis, and pelvic inflammatory disease. Okay, this was an important thing, we should know this. Okay.